I don't have an awful lot of updates actually, to be honest, but I'm happy to take questions, if anything for anybody that they want to ask about. Luke had mentioned that, some people might be interested in the cannabidiol therapy, which has sort of recently come into the fore with TS, and it seems to be getting good results. I'm sure we did talk about it a little bit the last time. The studies have been sort of focusing on patients who've had more than 8 seizures in the past 4 weeks and on at least one anti-epileptic medication. So that's relatively frequent seizures, really. And the mechanism of action isn't fully known. It's been shown to reduce inflammation, protect against neuronal loss, so it sort of protects against prolongs the life of the neurons, normalizes neurogenesis, which basically means that as the neurons are forming, that they're kind of perhaps forming in a more healthy way, and acts as an antioxidant, which means it's reducing chemical stress potentially in the brain as well. There's some sort of discussion about whether or not it acts differently with different syndromes. I suppose whenever we're thinking about genetics, that those patients with a genetic condition predisposing to epilepsy have an actual gene mutation, which is altering the function of neurons. So it's potentially theoretically possible that patients with different genetic mutations might act differently or respond differently to different treatments. But overall, it seems to be generally safe and effective for treatment-resistant seizures in children with severe early onset epilepsy. And I suppose that's kind of one of the key points is that, particularly with the likes of TS, obviously we're very much focused on children. There's been a lot of studies showing that if you treat epilepsy early and more effectively, then that has better long-term, they do better long-term with development and so on. And there doesn't seem to be as many studies with adults with retractable epilepsy, and I'm not quite sure. Hold on one second. Sorry. Sorry. So I've just been interrupted there. Sorry. So it's okay. Sorry, I'm at home. So as I said, yes, in terms of we do have some adult TS patients who have sort of difficulty, poorly controlled epilepsy, and it's not quite clear exactly how they would respond to the treatment and whether or not they would respond better or not. There's high oral bioavailability as well, which means it interacts with lots of other different drugs, including some anti-epileptic drugs. But generally, the medication is well tolerated long term. So the commoner side effects are things like fatigue or diarrhea, or perhaps a change in the seizure frequency or type, and abnormal liver function tests. So in terms of where we are with funding, and Luke again probably can update us a little bit more with this as well. There's a nice decision expected in England later on this year with availability for TS patients perhaps March next year. In Northern Ireland, it's approved for Lennox-Gastaut syndrome and Dravet syndrome for sort of similar situations. Lennox-Gastaut syndrome is a kind of multifactorial kind of syndrome. Sometimes patients, it's basically a severe epilepsy type syndrome with lots of different types of epilepsy caused by multiple factors, including some gene mutations, but also things like birth trauma or infection early on in infancy. So it's sort of multiple causes. Dravet syndrome is a specific genetic condition caused by mutations in a sodium channel within the brain. So sort of different types of mechanisms from TS, and it's sort of licensed for both of them in patients who are 2 years and older. And then only for a 6-month period, but to be continued only if they show a good response to that, which they would define as a fall in seizure frequency of at least 30% compared to what they had been before for the 6 months before starting treatment. So it's quite tight, I suppose, the inclusion criteria for that. We can chat about that a little bit after we're finished if anybody's more questions. Although obviously, from our point of view in terms of the TS clinic, it'll be managed more by neurology. In terms of our own TS clinic, we still don't have any face-to-face clinics really. It's limited in the city hospital. We're hoping that'll open up, but we're now trying to move to having video calls at the TS clinics where possible, and we've done that a few times sort of in an ad hoc way. But from now on, we're going to try and maintain, have video calls as much as possible going forward, because I think that's probably quite a good compromise anyway. And it has worked out well with our TS patients. We've had some TS patients who have requested a face-to-face appointment. We're able to see them. I've seen a couple of TS patients at the Children's Hospital, where I do clinics twice a month. So we are still able to see children face-to-face if needed to be. I've been approached, I think I maybe had mentioned this before, I've been approached by paediatric nephrology to try and sort of coordinate our clinics a little bit better with them. So we're hoping to work with them more closely going forward, and perhaps have designated paediatric nephrology TS clinics where we could sort of focus that particular clinic on the paediatric age group. With Everlimas, there has been some sort of issues with funding recently with Everlimas, and we're hoping to put in a business case to kind of have more streamlined funding for our patients, and hopefully that will go through satisfactorily. So that's kind of everything I wanted to update about the clinic, and I'm going to hand over to Rachel, who's going to say a few words about some research treatments.
Hi there. Yes, it's always good to have the Q&A, because that allows us to lead what you guys might want to know about. But I was kind of thinking, was there maybe anything that might be helpful? Some of the team in the TSA probably maybe know some of this. But I was reading some information recently from Dr. Darcy Kruger in Cincinnati in the States, and he is a neurologist with a specialist interest in tuberous sclerosis, and he's been doing a trial. So it's completed phase 2 now, and they're hoping to start phase 3 very soon. It's based on a drug called ganaxolone, and it is a neuroactive steroid, which could be an add-on therapy for patients with epilepsy that is not controlled well at all. And in a recent research from the study, about 23 participants had about a 16% reduction in TSC-associated seizures, and about 30% of the cohort had at least a 50% reduction in seizures. So that's kind of something promising. Maybe we have some patients that are on loads of epilepsy medications and the seizures are still not well controlled. And hopefully this is something that's kind of specifically looking at TS-associated seizures. So that's something that's happening. And then again, the TAND. So one of my favorite people in the whole world, Prof. Petrus de Vries, when he isn't on camels riding around the desert somewhere or doing something, he's always doing something very exciting on his Facebook page. He's obviously very interested. His primary interest as a psychiatrist is neurodevelopmental disorders. So it's something that's I'd be quite interested in as well. So that would be everything from learning difficulties to anxiety to ADHD, autism, the prevalence of that in the TS community. So some of his recent research, he had actually done a study. There was 894 participants, and they were looking at age, sex, and intellectual type to see if there was any correlation. So very basic. Obviously, there's more information if anybody is interested. Our contact details are at the end if anybody wants the paper or wants to read the research paper. I just thought we'd keep it short and sweet for today. So essentially, they did find was maybe what most of us may have expected is a heightened association with intellectual ability and TSC2. And that there was a male preponderance for ASD and ADHD, and that in females, anxiety would generally be more noted. He also had mentioned that you're more likely to see behavioural aspects of impulsivity, of ADHD, hyperactivity in children, but in the adult population, of patients that may be more likely to be kind of more psychiatric related. So there may be more obsessive compulsive, perhaps more psychiatric issues in the older population rather than in children. So that's really good to see. So I suppose anything surrounding that is really the whole theme of TAND is to have an understanding and awareness of all those neurodevelopmental and psychiatric issues that go with TS, and that we are really very much aware of what's going on for each patient in those areas. Because I know from speaking to patients and parents and families over the years that is one of sometimes the most difficult things to deal with. So that's really good to see that that's happening. And really then, as Deirdre said, we kind of didn't have too much to report. We thought we'd maybe let some of you guys lead with any particular questions. So it's just really our contact details. We are very much an open door clinic, an open door service. A lot of our patients are great at keeping in touch with us on a regular basis. They just email in. Whilst we do have the clinic and we do review patients on a regular basis, especially children, some of our families know that, anytime there's any issues, they can get in touch, whether that be by phone or by email to myself or Deirdre, and we can arrange to see them, or else try and advocate or refer them on if they need, actually if it's something we maybe specifically can't deal with. Part of my job in the clinic is arranging the appointments, trying to keep track on reviews, and keeping, really, I suppose our main role, as most of you may realise, is from the renal aspect, perhaps ordering scans. A lot of the neurology aspect will be dealt with by neurology themselves, but it also depends, with us being a regional service where our patients are based in Northern Ireland as well. So yeah, that's really it from me.
Well, I'll stop sharing the slides anyway, and we can just chat then.
Yeah, perfect. That's great. Thank you, Deirdre and Rachel. It's great to get an update. And yeah, just to carry on what you were both saying, particularly regarding cannabidiol. So yeah, that is our understanding as well. So we were delighted to get confirmation funding in Wales and in Scotland. So that went through. Wales went through towards the end of last year, if you didn't see. And just last month, the Scottish Medicines Consortium confirmed funding in Scotland as well. So in Wales, access to cannabidiol for TSC related refractory epilepsy should begin this month, all going well. And we're expecting it to be in May time for Scotland. Unfortunately, with NHS England, we're still working with them, very closely with them, to make sure that they come to the decision that they should come to. And Deirdre, as you said, you're correct. The earliest we're expecting a decision by them is in November. And if they do come to the correct decision, and if they do agree to fund, we would then expect access to begin in March. And probably teaching everyone on this call to suck eggs a little bit, but just in case you don't know, in Northern Ireland, treatment and medicine access tends to follow from NHS England. So that's why we're talking about NHS England here. Yeah, so fingers crossed. We're going to keep doing everything we can. It's great news so far with Scotland and Wales, and hopefully keeps going. And also on the ganaxolone trial as well. If you want to put it in your diaries, everyone, in April we have another event focused on epilepsy with Dr. Sam Amin, who I believe is involved in that trial. He's going to discuss findings with us there. So it's really interesting and exciting. It's going to be it's always fantastic to see possible new treatment options in TSC. But if there's any more questions for Deirdre and Rachel, and now is your chance.
I have a couple of questions. Can you hear me okay? Yeah.
Hi,
Yeah.
Hi, David.
I as you know,
Is there? Hi, Finn.
hello.
Hi.
Hello, Aileen. How are you?
Okay.
Good.
Yeah, I've always got questions, as you probably know, did. So I have a question for both of you, actually. So for Deirdre, you mentioned problems with Everlimas funding, and I don't know how much you want to say about that, but I just wondered, could you clarify, does that relate to new prescriptions, to existing prescriptions, and you know, what is the problem, or what are the implications?
I don't really want to say too much because it's sort of because of confidentiality issues, but it's basically, it was related to starting the drug up for a new patient, and there was some difficulties with that, more from a kind of admin kind of point of view. You know, there was I think the stream of funding from where Everlimas is funded through from the Belfast Trust is sort of changing, because I think it's because there's so many patients on it now, they want it to be more kind of have more mainstream funding. It's, you know, I don't think it should affect the existing patients on it at the moment, you know, but and I think it may affect patients being on it, new patients starting on it in the future. But I mean, I would hope that it's just sort of more of an admin blip rather than anything else, because there's so much evidence now about the need for Everlimas. There's such quite clear guidelines for prescribing and so on, you know, and it's obviously well tolerated. So I don't see it being a major problem, but the only reason I mentioned that is because, in case any of you had heard on the grapevine, that's, you know, somebody had had difficulty going on it. But hopefully this has been a blip that we can rectify, and that person got funding in the end. So
With a good streak for a long time.
yeah.
Okay, but as you say, Deirdre, sometimes it's just about getting those processes in place, which is hopefully we'll get sorted.
Yeah, that's fine, and I appreciate what you're saying, Deirdre, about confidentiality and whatever. I suppose just in relation to you know, situations which obviously impacts on even here, where there is an existing, you know, long-term sort of prescription for Everlimas. I think if we thought there were problems coming down the line, we'd appreciate knowing as much in advance, early in advance, because obviously there's things that clinicians can do about that, but there's things that other people can do as well. They just need time.
Yeah. So, we're happy to round up the troops if need be, if we have to go complaining, but hopefully it won't come to that.
Okay. And just in relation to what Rachel was saying, or you were saying, Rachel, you were talking about Petrus de Vries's research and about the prevalence of psychiatric disorders being higher in adults. I just wondered, is that something, those psychiatric, did the research sort of cover whether that increase in psychiatric disorders is like an onset of psychiatric disorders, or is it something that sort of intensifies but has always sort of been there?
Yeah. So I'm by no means an expert in this area, and there's maybe some people connected with the TSA would know a wee bit about this as well. But essentially what their findings were, that was, as I said to you, that the children would experience more of obsessive. Some of the behaviours that they did report in the paper may have been maybe some self-injurious behaviours, maybe whether that be down to you know, some quite distressing psychiatric disturbances. What they were obviously, what the research was showing was that was associated with intellectual ability, and that was higher in the patients that maybe, you know, struggled a little bit more in that area. Your question, if I'm right, just to make sure I've understood what you're asking me, is that was that noticeable as a progression from something through childhood into developing into psychiatric disorders? Yeah. I'm not 100% sure. I say I can't. I have read the paper, and I do keep an eye on that type of research, because it is something I am interested in. It's quite close to my heart. But there was an association with the intellectual ability definitely confirmed in the research, but not necessarily that the ADHD, the obsessive, maybe the hyperactive impulsive behavior led to the psychiatric issues. Again, it was noted that they were no more prevalent in boys. It is quite interesting. So if you look at ADHD and autism as a whole, separate from TS, we do see that those symptoms are, those ADHD characteristics are so much more noticeable in young children, and especially young boys. And therefore, the understanding often would be is that girls mask it better, and that actually they can end up with anxiety issues as they grow older, because of, as a result of masking, they can mimic, girls generally can mimic better. They can kind of mimic those behaviors that they think they're supposed to do, and those things they're supposed to say that are kind of, I suppose, within social norms, whatever that's, whatever that is. So it means that I suppose there could be a connection with that as well. As often individuals with TS are more susceptible. We do know that, to sometimes having these neurodevelopmental, but these things also exist as a separate entity in patients that don't have TS. So it could be that that's why it's more prevalent in boys. It could be that maybe that's why. And obviously then we also have the association between epilepsy. And we do know that the more seizures patients have, potentially then that can become very distressing for them as well, and can lead some of our patients as well. I wonder, for those patients that experience quite a severe intellectual phenotype, we aren't always sure sometimes of those patients in some discomfort and pain. So often that can be an issue as well. Maybe if they can't verbalize, are they uncomfortable? So often that's something that needs to be taken into consideration as well. But there wasn't necessarily a definite correlation between, having somebody who's maybe hyperactive as a child ending up leading to a higher risk of psychiatric. But it is interesting that it is females that end up with more anxiety. And we do know that women and girls with ADHD, ASD will mask better, but all that masking, it's like holding everything in and holding all the stress, and then it can come out. It can come out in other ways and can manifest itself as mental health, psychiatric anxiety disorders.
Thank you, David. That was two really good questions. Just so you know as well, from the TSA's perspective, I'm not aware of any research to specifically answer the second question that you had, but just more broadly, TAND is a major focus for us at the moment, and it has been for a while. So, for example, the research funding this year, the funding round is focused on TAND, and I think virtually everything that we do has a TAND focus within it, and which it rightly should do. For example, there's we're hoping, well, we're in the process of developing, not hoping, we're developing a series of training modules which will help upskill social care professionals and education professionals about TSC. They'll be accredited with education points and things like that for their best practice, and there's a whole section on TAND, for example. So it is something that we are very much focused on. Yeah, so thank you. But as I say, unfortunately, I don't know the answer to the direct question, but it is a focus. Are there any more questions for Deirdre or Rachel or me even, or the TSA?
I actually do have another question. I was sort of
go for it, David.
I didn't want to sort of just sit here for half an hour pumping questions at people. Just I don't want to get the reputation of being the sort of school swap, but I was reading Scan and there was some talk about this new development around a TS clinic network. And I just wondered if there's something you could tell us about that, both if it has any impact on the way that the Belfast clinic does its work, but just generally what this network amounts to.
Yeah. So I'm happy to answer that. So the NHS TSC clinics network it's a new project by the TSA. Although I say new, to be completely honest with you, David and others, it is something that sort of was already happening, but it's just a little bit more ratified now. So we're always keen to maximise the jaw dropping and incredible work that every TSC clinic does, such as Deirdre and Rachel. Everyone on this call knows the great work that the two of them do. And the TSA, we see ourselves very much as being able to help with that. So we've identified a number of ways that we can do that. They largely include, for example, getting clinics to communicate and learn from each other a lot more, because there is, due to the nature of some clinics are really, really big, some are really, really small. We feel, and the clinicians that we've spoken to feel, that they can benefit from just connecting a lot more, because historically we only did one big TSC clinics meeting a year, which was very, very useful. But now, because everyone's savvy with Zoom and everything else now, and we can have sort of emails going across and everything else, and newsletters, we felt it was a good opportunity for that. And we also want to try and work more to tap into the different expertise that are within every clinic. So, for example, if there was a desire for a LAM expert or information about LAM within Northern Ireland, perhaps it would be that Deirdre or Rachel will get in contact through the network with Professor Simon Johnson, for example, who may be able to give some brief overview or his information recommendations, whatever. Professor Simon Johnson, the director of the LAM Centre in Nottingham. So it's, yeah, that's essentially what it is making sure that we're helping the different clinics the best we can, and we're starting off by just ensuring that the different clinics are connected as well as possible, and we're going from there. We're hoping it will build more and more. We're also hoping that the clinics will be no pressure, Deirdre and Rachel, but we're also hoping that the clinics will be able to help us more and more with the TSA support line as well, because we now and then will receive medical questions. We're not medical professionals, we cannot answer them unless it's information that's widely distributed already. So it could be that we get a few clinicians and experts who can help us from that side as well. But hopefully that helps answer, David.
Thank you.
So good question, David, because I was interested in the answer to that as well. Really good question, David.
It's going to look like it's going to happen just because we've had this conversation. So I have to tell you now, the first email that's going out to all the clinics is going out tomorrow. So keep an eye on it.
David, you're ahead.
Just in case you saw it and you thought,
well done. I'm going to prep you for future meetings, David. You wouldn't ask about. That'll hopefully be really good, though. So I suppose effectively, Luke, it won't change how we work or run our clinics. What it means is essentially it's more like a communication network.
Absolutely. We wouldn't dream of telling clinics like how to run the clinic, because the clinics are the absolute experts. But it's just a way to maximize communications is the main thing. Exactly, Rachel. Yeah.
That sounds really.
It might be possible if we're doing virtual clinics that we could potentially get somebody like Professor Johnson to join, to sit in on a call, even if we felt that was necessary. Although he does work fairly closely with the respiratory physicians in Belfast Trust anyway. So, but even anything that kind of just strengthens those links or makes them more, uniform is a great thing.
Yeah, superb. Yeah. That's exactly what we want. And the ultimate aim is just to make sure that everyone in the TSC community, whether you live in Belfast, Wick, Sunderland, London, it makes no difference where you are, and you get exactly the same standard of care, and you should expect the same standard of care.
And it's funny,
I think that's the sort of thing that, sorry, that kind of standardization of care is the sort of thing that will help sort of allow standardization of medical treatment as well, you know, and you know, quality and you know, throughout the whole of length and hours to get any of the new
Yeah.
coming forward, that sort of thing.
And I think whilst I'm never keen to say that the positives of COVID, I think what going through the pandemic and being able to do things like this, and I know even for my own Northern Ireland, you know, we kind of, that wee bit of water between us and elsewhere seems to make a big geographical difference. And even just for my own practice and work and being able to attend conferences and being able to go to things, being able to have video calls or telephone calls with patients, you know, that maybe was just a conversation, it wasn't necessarily an examination, and that the choice is there. And as Deirdre says, being able to kind of possibly have a call where you've got a specialist who can just pop on. I think this would have probably happened eventually, but it's certainly sped it up, which I think there's so many positives too.
Yeah, absolutely. And we've been hearing similar things from other clinics as well. In particular, say for example, in Scotland, where previously someone would have to travel, and in Wales as well, incredible distances to get to a clinic. Whereas now, exactly as you said, Rachel, obviously the pandemic wasn't a good thing, but it has pushed the technology and the availability for things like this. So yeah, so hopefully that is a very small chink of light that we can take from it moving forward. Yeah, and again, I suppose that's where the clinics network comes in as well, because it means that people are a lot more open to it now. Yeah. Was there any more questions or thoughts from anyone? No, last chance. Right. Okay, well, I guess we'll leave it there then from everyone. But thank you so much. Honestly, it's always great to connect with people and to really to speak to people who are in the TSC community a little bit more directly. Obviously, we're in contact on email and web chat and whatnot, but it's always nice to actually see people. So keep an eye out for future events. We do have a nice calendar of events now. 90% of them are confirmed. We do have a few more that we're due to put in the diary and things to let people know about. As I said at the beginning of the call, the next event is in 2 weeks. I can't remember what the date is, 23rd, I think it is. TSC in the kidneys with the St. George's Clinic. I can remember the St. George's Clinic, but then we do have a lot more coming up as well, including the TSC in epilepsy event that I mentioned with Sam and Min to look forward to in April. But other than that, just keep in contact, and hope everyone stays safe. And Rachel and Deirdre, keep an eye out for the clinic's email.
Yeah, thank you.
Okay.
Thanks very much for organising everything, Luke.
No problem at all. It's a pleasure. Okay then. Bye bye.
Thanks,
Bye.
everybody.
Thank you.
Bye.
Bye.
Bye. Bye.